Wilson. I'm the spa director for Rejuvenate. And Rejuvenate is a vein clinic. It's also a medical spa and a retail shop. So we also do facials and massage, as well as we have retail products for sale. So we welcome you to our new facility. This is a brand new facility that just opened this weekend, actually. Some of you may have gone to our old practice, which was right next door. We bought that from Dr. Campbell, and he retired, and Dr. Rank took over as the vein clinic. So we just decided to kind of expand our services a little bit, offer a little bit of wellness procedures, and I think that's kind of the osteopathic background, is looking at the body as a whole system instead of just individual systems. So Dr. Rank is our medical director. He's been in practice for over 30 years. Did his residency and some fellowships at Cleveland Clinic and also Grandview Medical Center, and has primarily focused on vascular surgery for the last 15 years. So we are proud to have him as our medical director for Rejuvenate. And he's going to talk today a little bit about the history of venous disease and also some of the modern treatments of venous disease. So thank you all for coming today. Dr. Rank.
Thanks, Chris. Thank you very much for coming. And I'd also like to thank our host back there for our goodies that are provided around, so as well as the education she's going to give you about the hose, etc. So that's kind of nice. As I was thinking about how I was going to talk about this, I was kind of stimulated by a new show that's on television. It's actually on Cinemax, which is kind of interesting. It's a show called The Nick. And The Nick is a show that talks about a surgeon at the turn of the 19th century. Well, actually at the turn of the 20th century, in 1900, and it's this hospital called the Knickerbocker. And watching all the things that have transpired from then until now is quite an interesting, shall we say, debacle as far as how gross surgery was when it first started and what it is now. Quite a transition. And so that stimulated me also to say, well, maybe I should look at a little bit more about how veins got started. So I made actually a couple of notes because there was so many different names that I couldn't pronounce half of them. I made just a few little notes, but I want to tell you. All the way back to 1550 BC, the Egyptians, on some of their papyrus, you know, the sheets that they had, they started talking about veins. So that's a long time ago. If you look at some of the ancient sculptures in Rome, they have big varicose veins in some of the people. There's pictures all over the place in our various vein books. There are, back in Hippocrates' day, back in 400, he was one of the first people who ever decided to start treating veins. And his descriptions were two. One, he would beat them with a stick of some form. He wore a metal object, beat them until they were flat, and then he would do bloodletting to help try and thrombose them. That stayed the treatment for almost a millennium, which I was really kind of surprised. But the history says that there was almost no change in that for a long period of time. Well, then, let's see. In the first stripping and cauterization, I started right around 30 BC, which was where they actually went in and pulled out without anesthetic. Remember, there was no anesthesia for a long time. So they started stripping and cauterizing. And what they would do is they'd take hot coals and they'd cauterize the ends of the veins. Interesting, but not what I really wanted to have done to me. There was another guy named Antilles who did the first true ligation. Doesn't say exactly what he used, but I would imagine it was twine or something like that to go in. He found it, tied it off. Interesting. In 660, there was a guy by the name of Galen who did the first hook phlebectomy. Now, that is a long time ago. Now, 1,500 years later, hook phlebectomies is the mainstay of treatment. Now, what he used to hook them with, I don't know. What he used today looks very much like a crochet needle. And I'll talk about that a little bit later. So when you look at that whole situation, just that transition over that period of time, it took a long time to make advances. First of all, we didn't have cell phones, we didn't have the internet, we didn't have instant gratification of knowledge or news or information. Compression therapy, which is what we're talking about today, also started with the Romans. You know, you watch all kinds of movies that have Romans, you notice how they have leather straps all the way twirled up and with their sandals up to the knee. That was the first form of compression. They did that for relief of vein pressure on their long marches. Remember, they marched 15, 20, 30, 50 miles a day. They wear those straps. It took until that kind of continued, various forms of that for a long time, and then in 1676 they came out with laced leather hosiery. Kind of interesting. Could come a long way. I think you were getting a little bit of information about that when I walked in. So, the first injections were kind of interesting. They started in the 1600s, I think it was, and then they started using, at that time they used kind of like a honey sugar solution trying to close it off, but in 1916 the guy by the name of Lisner used if you old enough to remember mercurochrome, merthiolate and those things, he used a form of that and injected it. It was really great. He got great results, except for the complications of using that, which could be nephritis, stomatitis, where your mouth swells shut, or he'd have sometimes intestinal problems, or he'd have enteritis. So it was a great thing for the veins, but not for the rest of the body. There was another guy who had tried to use a form of nitric oxide, and his first two patients that he injected to walked 2 feet and dropped over dead, so they decided not to use that anymore. So the history of sclerotherapy is kind of an interesting problem as far as what people would do to try and make things better for you. One of the things that I found interesting myself as I was researching this a little bit more about sclero, the things that we use today, the two mainstays, one of which we use here, which is called polydocanol, was actually founded in 1966. There's another one called sterolactate, which is very similar, is found in 1946. And one of the things that has gone completely out of usage, except for a very rare occasion, which is hypertonic saline, they started using that first in 1969, actually after the other two things that are our mainstays today. Which I found, again, you read about the history of medicine, you find all kinds of things out. First of all, a lot of things repeat themselves, despite, you know, they think they found something better and then they go back to what worked in the past. Now, I had enough about the history, but I wanted to tell you a little bit about the anatomy and what we deal with. And some of the also things with the history, as they found out initially in the 1600s, as they started to define the venous system, where the heart, the portion that returns blood to the heart. Well, it's dependent upon the heart to push things through. Gravity is its enemy. On the arterial side, on the outflow side, gravity is its partner, its helper. But gravity doesn't do you any good when your valves which are in the veins, don't work. And hence, that's a good portion of what our problems that we are presented with in vein clinics are. Valves not working. You see there in front of you with the Kentucky blue is the superficial veins, and the North Carolina deep system. Okay, we deal here with the superficial system, and of course I'm very happy about that since I have 2 boys at the University of Kentucky right now, so it's kind of nice. But you see that it has a small saphenous, which is on the smaller leg, and then the greater saphenous, which is on the larger leg. The greater saphenous goes into the deep system and empties superficially around the leg. We use that greater saphenous in heart surgery all the time. So for 29 years, I worked on preserving that great saphenous and utilizing it on hearts, but now I try and get rid of it. Why? Because I realize that when it's to the point that I have to get rid of it, we couldn't use it in heart surgery anyway. It's way too big, it's too tortuous, it's full of balloons and things like that, so not useful. How does it help by taking care of these veins, stopping the reflux? One of the things that was found out, and really it's only been in the last 20 to 25 years that the study or the treatment of veins, now called phlebology, it has its own name now, really took off, where people actually started doing more research into mechanisms. How does, is it going to be beneficial to take this out in the long term? What happens if you don't? We found out a couple of things. That by taking out these extra veins that go backwards, the pumps on the deeper systems now can work more efficiently. They don't have other places to put it. They don't have these extra causes, they don't have the extra systems. Now they only have one place to go, up and out, the way they're supposed to. They don't have extra avenues. Their choices are cut down. That becomes important. There's been enough studies also that show that by taking care of not only reflux, but reflux between the superficial system and the deep system, which is called the perforator system, that area will, first of all, lead to ulcerations if it's not fixed. And second of all, by taking that again away, flows where it's supposed to and not in the way it's not supposed to. So, any kind of reflux, whether it's the great saphenous, the small saphenous, or in the perforators, by treating it, we're able to decrease the wrong flow or aberrant flow into the correct flow. Now, how do we do that? Well, there's lots of different ways. The old-fashioned way was kind of a little bit of what I mentioned, which was ligation and stripping. Go in, make incisions. They used to be big incisions, and the incisions over time got smaller and smaller. Come on in. All right. The incisions got smaller and smaller, and they got to the point where we can now take, if we have to strip a vein, we can actually do it with a scope and through two little incisions this big, as opposed to incisions this big, both in the groin and the lower portion of the leg. That has changed. We use that both in heart surgery, where we're trying to use the vein to a good portion, or when the vein's no good and we have to take it out and we can't do it in here. So that's the stripping portion. But what are the other portions? Well, there's three other main portions. One is by radiofrequency ablation, which we have chosen not to use here. I think it's longer, harder, and from what I hear of patients that have had it, a little bit more painful. There's laser therapy, which is what we do as a mainstay here. The laser therapy, has gone through tremendous differences in wavelengths. What they've done is they've been able to find what is the best wavelength, the most effective wavelength, and the easiest, the one that hurts the least and is still effective. Those are both important. What's next? Well, the newest thing, and I saw this now for 2 years at the National Convention on Veins, it hasn't been approved yet. The first year they introduced it, the second year they were pushing it, but interestingly enough, it hasn't been approved. And that's actually injecting a sclerosing agent where we put our lasers in and sclerosing it through a specific instrument all the way up to the junction that you see there with the dark blue and the light blue, okay? Injecting it all the way up to that agent. Right now, that's not approved, and it's approved maybe in Europe, but not here.
What does that do?
It just closes it off by chemical means as opposed to either radio frequency or the laser, which steam closes it. So that's a good question, but they claim in their trials that it's very effective, but nobody's using it yet. Maybe in centers, but not for the general public. And I don't see any advantage to it at all at this point. It seems like you have more recurrences where the veins open up later on.
Do they still use the saphenous veins for anything?
Yeah, we use it every day for heart surgery, but the ones that we take care of here, they're way too big. They won't work.
The reason I ask is my son works for the blood bank and the tissue. And
Oh,
tissue
well,
bank. And
the only thing that might possibly be is whether or not they would be used for a bypass, because sometimes they can be used for bypass. But again, that bypass would be peripheral bypass, and most of the time if they're that big, they're tortuous. They have little varicoses along the way, and they just create more problems than they are good.
I remember when he came home, first time he came home, he says, "Mom, I salvaged 63 inches of saphenous vein today." And I go, "Wow, that's great." And I'm going like, "Oh, okay." My little Frankenstein.
There you go. So, that point of reflex that is on your diagram there, the thing that's important about that is that when we use the laser, I have to stop about a centimeter to a centimeter and a half, which is just about your first knuckle on your index finger, okay? And we have to stop short because the extent of the laser, the way it works a little bit further than its tip. If it goes too far, it causes clots. Clots in places that we don't want, or it can sclerose the main vein. And that's the biggest complication that we worry about when we do that type of procedure. And then, of course, Dan's going to talk to you about that later on, but Dan will look at that after we've done it the next day or 2 or 3 days later, depending on our schedules, to look to see that it's closed and to look to see that we don't have any clots. Now, let's talk about some of the other things. The varicoses. People say, well, why do you have to take those out? 3 reasons. 1, they can ulcerate. 2, they can thrombose. And 3, they can get infected. All 3 are bad, okay? So we take those out, especially when they're associated with reflexing saphenous veins that we just talked about. Those things, on people who don't get them done and treated, they'll say, well, they don't hurt me, they don't bother me. That's fine. But the first time they start aching and hurting, that's when you need to get therapy, because that's then the precursor of all those things I just talked about. Blood clots in the veins, infection in the veins, or ulceration of the vein leading into the skin, okay? Perfect example, we just saw some guy who had had the veins for 20 years. But now all of a sudden they started hurting. We did an ultrasound and he was clotted from below his knee all the way up to his junction, and the 2 great big sets of varicosity he had were also clotted. He was beyond what we can do here. I have to take him to the operating room and do that, because for safety's sake and for completeness sake. Okay, so there are advantages to getting it done sooner rather than later. There are some types, veins are divided into spider veins or telangiectasia, reticular veins, and varicose veins. They are divided by size. Spider veins are 0.1 to 1. The reticulars are 1 to 2.5, and varicose is anything other than 2.5 and bigger. We see some as big as 10 millimeters. That's pretty big. It's about the size of my little finger. Okay. And yes, we can still get those out here, but we have to kind of turn it upside down. No, not quite that bad. But we do make ways to help
Have a wrap.
cut them down. The stuff that we inject around them, the anesthetic, it's called tumescent. It has involved in it 2 different things that, 1, help shrink down the vein, 2, help cut down the feeling around the vein. All helpful in getting the veins out. So that's the varicose, the reflex side. Then there's the other side, the telangiectasia, the spider veins. The ones that most of the time are considered cosmetic. However, there are some that cause tremendous burning, stinging, and aching on folks, and those most of the time are treated by one of 3 methods. 1 is simple injection, 2 is foam injection, and 3 would be laser. Laser's limited a little bit on the scope of what you can do with spiders. There are kinds that do work. There are other kinds that it's not as good a result. You're looking for the best cosmetic result. When you're talking about spider veins, you're talking about an ongoing process. It's not something that happens once and is done forever, but it's something that you keep after. And the more you keep after, the better they're going to feel and the better they're going to look. That leads us to the next portion, compression. And compression is a very variable thing. People look at it different ways. I wore my compression hose for 22 years. The first ones I ever put on happened to be Sig bars, and they're still in business, and they're getting better and better, as are their competitors. They've forced the market to make hose that are 1, comfortable, 2, aesthetically pleasing, and 3, adaptable. So all these things are quite good as far as making it able to make you comfortable and yet still help you. So compression hose are helpful in the beginning as we start to evaluate you and treat you. They're helpful during the treatment phase, and then after the surgical or treatment phase, they become something that you can depend on to help you in the long term. A lot of people differ on how that can help you in the long term. Some people do not believe that once you have the surgery, you're done with it. Others, a lot of people that come here are teachers. They stand all day long. Or people who work in the hair industry stand all day long. When they're standing all day long, again, what we talked about right in the beginning, gravity, right? Gravity is your enemy. It's going to bring all that extra blood down. And what happens if you wear a hose? It keeps it from puddling and pooling and helps you get rid of the aching, swelling, and pain. So even after surgery, they can be very, very beneficial. That is kind of a wide description. I'll take questions if you have some.